Record. Hi, everyone. I see people starting to filter in. It is so good to see you. I am Anne Marie Doyle. I am Director of Community Education here at the Les Turner ALS Foundation. I am just double checking. Great. Let me share my screen. I've got a couple housekeeping slides that we can um, get started with. So welcome to our October ALS Learning Series. Um, we always just want to give a wonderful little shout out and thank you to our industry sponsors, Mitsubishi Tanaba Pharma America and the Gilbert and Jacqueline Fern Foundation. Without their support, we wouldn't be able to do this. We know a diagnosis of ALS can be really challenging and you may not know where to turn to next. And that's where we are happy to help. If you have any questions about decision making or information guides, um, if you want to check out any past ALS learning series, you can find all of these incredible educational resources on our website at lesturners.org. And right around the corner, next Monday or this coming Monday, we have our Les Turner Symposium on ALS. Dr. Don Cleveland is going to be talking about kind of his work in ALS and kind of this idea of the idea to drug pipeline. So it should be a can't miss. You can join virtually or in person. Just visit lesturners.org/symposium and you should be able to register. And then, of course, we always want to give a shout out to our partners at the CDC and the National ALS Registry. You can visit cdc.gov/ALS. This is a wonderful registry for people living with ALS. It helps us learn more about the disease, who gets the disease, when symptoms start, and it also gives researchers a great way to learn more about ALS. So if you're interested in joining the registry, we highly encourage it. Visit cdc.gov/ALS. And with that, I am so excited to be able to introduce you all to a former colleague of mine, Hannah Red. Hannah specializes in providing patient care in the area of neuromuscular disorders at the outpatient neurologic clinic at Shirley Ryan Ability Lab. Hannah is currently an adjunct faculty member with the Northwestern University Department of Physical Therapy and the Human Movement Sciences, and has previously been on faculty at Byradine F. Lewis College of Nursing and Health Professions at Georgia State University and Emory University School of Medicine. Welcome, Hannah. And
Thanks,
I
Amory.
will stop sharing my screen and make sure that you can share your screen.
Great.
Oh, and while Hannah is trying to get that up, just a reminder, our chat feature is disabled right now. You may see me dropping some links in the chat. You should be able to access those. But if you have any questions for Hannah, she's going to leave time at the end of this session. Please put any of those questions in the Q&A box. That would be great.
Amory, it says that sharing is not turned
Oh,
on.
how about now?
There we go. Perfect.
Awesome.
Okay. Perfect. Thank you guys so much for having me. And I always look forward to working with Les Turner Foundation such a great organization. As Anne Marie mentioned, my name is Hannah Red. I am a physical therapist for almost 10, no, 12 years now. And I am originally from Atlanta, but have made my way up to Chicago and work in the outpatient neurological clinic at Shirley Ryan Ability Lab. I split my time there between patient care and research, especially with people with neuromuscular disorders and neurodegenerative diseases. And today I'm so excited to talk through, kind of give an overview of something that's near and dear to my heart and something that I get to partner with people with ALS and other diseases every single day discussing. And I know Anne Marie said that quite a few questions had already popped up in this area. So just really talking through kind of functional mobility changes. What are the things we can expect and maybe plan for? And then how do we best do that with an ALS kind of partner care team? So just quickly, things we're going to go through. Going to talk through some of the things that we can expect with functional mobility changes with ALS. Talk about some of the most frequently prescribed mobility aids, including transferring and walking and standing, things like that. Give you guys some information on community resources for mobility aids. I know that this is always a hot topic with my patients on how do we get access to these. And then just talking through what is partnering with an ALS rehab provider, especially in the area of managing mobility concerns, look like. So I put this up here because this is something that I feel like I say every day. Um, with ALS, we know that there are some predictive models and some things that we benchmarks that we can look at to determine how someone's progressing in their mobility challenges. But a lot of this is unexpected. Everyone is unique. Everyone progresses slightly differently. I work with people with ALS almost every single day in the clinic, and I talk through, um, hey, in my experience, this is what happens, and in the literature, this is what most commonly happens. But then we always come back around and want to make a unique plan that fits their needs, because truly, it can look a lot different than what we think. So I put this up here just in the realm of talking about mobility changes. I thought this was interesting. This is from a 2017 study that polled people with ALS, just looking at most commonly reported symptoms. You can see those top reported symptoms include fatigue, muscle stiffness, cramping, shortness of breath, difficulty sleeping, pain. I'm sure those of you here that either have ALS or have a loved one with ALS have seen some of these. And then you can see that second column, a lot of those may be non-motor symptoms, but even those non-motor symptoms can have a real impact on motor symptoms and mobility and motivation and things like that. So I want to keep this in mind when we talk about things that might impact mobility and how we address some of these. Whoops, bounced ahead. All right. Oh, I'm so sorry. It's bouncing ahead multiple times. There we go. So just a quick review of just typical ALS disease progression. I thought this might be helpful when we're discussing kind of how we plan for things. Most often with ALS, we start to see, especially in that motor category, motor meaning how we move versus sensory versus how we feel and touch things. So motor, we most generally see a distal to proximal pattern. Distal meaning away from your trunk. So, for example, we generally see more weakness in the ankles versus the hips to begin with. That distal weakness through the ankles or lower legs usually starts to progress towards the trunk, and then same with the arms, where we generally see that weakness in the hands and fingers prior to maybe the shoulders and upper arms and trunk. Generally, we see more early on, we see more flexor involvement versus extensors. Flexors meaning we want to bend something. So, for example, I want to flex my fingers down versus extending them. And we generally see that in the lower extremity, meaning the legs, and the upper extremity of the arms. Um, okay. So, when we talk about ALS and things that might slow you down or might affect mobility, I just mentioned some of those non motor symptoms that could have an impact on this. But just so we're kind of all on the same page on what we're thinking through, when we speak of kind of that early or new diagnosis, we're generally speaking about more mild to moderate leg or arm weakness. Again, that distal weakness, like I mentioned, ankle weakness or finger or hand weakness. All right. And then generally, people are starting to report some limitations to endurance and fatigue. Maybe you're able to do some of your normal activity or most of your normal activity, but just a little bit more effort, maybe more rest breaks needed, things like that. Starting to experience some shortness of breath. That middle stage progressing weakness, we start to see that progression up the legs, up the arms, maybe some trunk weakness. This could lead to some difficulty with maintaining posture. That's either in a seated position or a standing position. Some people start to have a lot of difficulty with neck weakness and holding their head up. Um, Progressive shortness of breath with exertion, especially maybe not so much when people are sitting or just resting, but when they're trying to complete a task. And then decreased balance and balance confidence. This is generally where we start to assess a lot of these needs for mobility aids and fall prevention. And then that later stage, we start to see more progression in the weakness, especially if this hasn't already occurred, more involvement in the arms and hands. Generally, people may have already had a need for a caregiver to assist with some activities, but this would be where maybe a caregiver is doing a lot of the effort with mobility tasks. Maybe someone might be dependent on a caregiver to perform a transfer or sit to stand, things like that. And then maybe a possible need for additional respiratory support. And I mention this just because, as we can imagine, that with increased shortness of breath, increased fatigue, decreased mobility, it starts to really affect how much activity someone can tolerate. And this plays a lot into what kind of mobility aids we suggest for people. Just thinking about what do they need to do and what do they want to do throughout the day. All right. So, how does all this affect mobility? So, as I mentioned, that this can often transpire through mobility needs. So, I kind of polled a lot of my patients that I'm seeing right now with ALS that, hey, what are the top things that really matter to you and you find the most difficult right now? Most reported was difficulty standing up from a seated position, which this is probably the number one priority I hear from people. People say, I want to be able to stand. I want to be able to stand to do things like stand at my sink or to stand in the kitchen, to get dressed, things like that. Difficulty rolling in bed or just generally getting in and out of bed. Just generally difficulty transferring, maybe transferring from a bed to a chair, to the toilet, in and out of a car. Difficulty with prolonged standing, so more than a couple minutes of standing from a fatigue perspective and a balance perspective. And then just generalized difficulty walking, maybe seeing increased need for caregiver support, mobility aids, things like that. All right. So when we talk about some of this change in function, we want to think first and foremost, I try to talk through with my patients on what are options. And this goes into a giant web of options. So I'm going to give an overview of some of the most common options that we prescribed. That does not mean that these are the only ones available. I focus on these because I want to be cognizant of people's various situations, financial situations, insurance situations, even things like, will a piece of equipment fit in your home? Can it be transported? Things like that. So we're going to talk a little bit later on just what are more of those considerations we have, and that just because someone with ALS gets one piece of equipment doesn't mean that everyone needs that piece of equipment. All right. So when we're thinking about transfers, and I know that Anne Marie mentioned that several people submitted some really great questions before the talk today, just asking, how do I transfer? How do I teach my caregiver how to transfer? How do I make sure I'm safe during a transfer? So, really great questions that I appreciate. Just a few things that we typically see. So, I want to mention the transfer boards that you'll see in that first top picture between the couch and the wheelchair. We're not going to go into specific brands and types of equipment today because there's so many. And this is where you can meet with a physical therapist and talk through different options, different brands that are available to you, insurance coverage, things like that. But a transfer board is generally one of the first things that I start to work on with someone is it's a really low tech. This one has a seat that moves with you. But when transfers or standing becomes a little bit more difficult, this is a great option to serve as a bridge between two surfaces to kind of perform what we call a squat pivot transfer. That would mean that you're not fully standing, but you and a caregiver or you and a family member are doing some of the effort to bridge that gap between a chair and then a sofa or a chair and toilet. This is highly transportable. A lot of people use it to get in and out of a car from a wheelchair. A lot of people use it between a chair and a toilet, any two surfaces pretty much. And then we often use a tub transfer bench, which works in the same way. This fits over the lip of a tub, makes transfers in and out of a chair and in and out of a tub much easier and safer. I generally typically use these with things like grab bars or some sort of secure handle. Um, Down on the bottom, these are two lifts that I always get questions about, especially the sit to stand lifts. So the one that you can see in the bottom corner with the nurse is assisting her from a hospital bed. This is a pretty typical sit to stand lift. And so many people see these. And I think it's a great option, but it's something that I really ask people to consider where they're at and maybe how has their ALS been progressing or staying stable. I see a lot of people that see these. It's a device that kind of scoops you up and helps you stand. Really great device. However, it's made for people who can really balance themselves and have upper extremity strength to hold themselves up, but maybe their legs can't hold them up. So it's a great device, but considering if you don't have the head control or the trunk control to hold yourself up, it really becomes a piece of equipment that isn't super safe to use. It doesn't have a lot of back support or side to side support. So, really, I try to have people think through, is this a good option for where you're at now? Is this a good option for where you're going to be at in a couple months to a year, a couple years? One thing I try to be cognizant of when I talk with people with ALS is there are so many equipment pieces out there, and a lot of people want all these pieces of equipment, but I don't want your house to be full of equipment that maybe in a couple months, a year, 2 years, you can't use. So I partner with my patients to really figure out how can we make the best decision and find out what's right for you. All right. And then this last picture, you'll see the lift. This is a very typical mechanical lift that we use. Pretty much any PT clinic is going to have one of these to trial. They're very prevalent. This is has the capability to do a completely dependent lift, meaning that sling can be brought all the way down to the floor or to a bed, a car. I think I have gotten a patient in and out of just pretty much any situation with this type of mechanical lift. It's super common. I train people almost every week, patients and caregivers, to use this. So very typical. Sorry. So when we go through, we're kind of working our way up from transfer to walking and standing. So when we talk about walking and standing aids, wanted to give a list of some of the things we're going to cover, and then I'm going to talk through some of those considerations. But depending on your situation and how you and your physical therapist or occupational therapist or therapy team in general is assessing your ability to walk and stand for at least a few minutes safely, We might go down a straight cane, a four-prong cane, which can have a small or large base based on what's safest for you. Things like a rollator, which I'm going to show you a picture of. It again can have a small or large base. All right. And then a rolling walker. You could have a four-wheel or two-wheel. You can have a platform walker that helps maybe get you upright a little bit more. And then considerations like orthotics, which we'll talk through in a second. And then standers is a pretty common piece of equipment that I prescribe with my patients. So just to give you a few pictures, if you're not familiar with this equipment, canes there on the side. Most people are pretty familiar with these. The size of the platform can change based on your balance needs. This would be for someone who is currently walking, is maybe able to walk with what we call supervision. So, meaning I want someone with me, but someone doesn't need to be holding on to me for me to not fall. Or someone who could walk independently, meaning walk by themselves, but maybe is limited to shorter distances. Maybe they're just walking inside their home right now, or pretty short distances in the community. This might be a good option. And then we have our walkers and our rollator, those two middle pictures. The top picture is a pretty typical rollator. I do also want to just mention that some of these pictures have logos on them. I'm not endorsing any specific logo or type of device. These are just examples of equipment options. So the top is a rollator, which is a four-wheel walker. You've probably seen people in the community use these. Super efficient. It can act as a seat. You can lock the brakes on it and act as a seat. I like this option. However, again, when we're planning, this is a device that if you don't have really good balance and the ability to start and stop yourself, pretty independently, not a safe option for someone. I've seen many people try to use rollators in the community, and because it's on wheels, it can get away from you if you're not able to start and stop yourself pretty strongly. So again, it's something that you would want to assess with a PT to make sure it's a safe option for you. If that is a little bit too unstable for you, we could always go the route of a walker or a platform walker, which are those two kind of blue walkers on the bottom. Very stable options. The typical walker you've probably most likely seen is there on the left, the shorter one, and then a platform walker is on the right. I find this most helpful for people with ALS who are maybe having more upper extremity involvement, meaning your hands and arms are more involved, but they need some balance support. Those platforms that you see allow your forearms to rest in there. And then those two bars on the front can be gripped by your hands. They don't have to be gripped by your hands. A lot of people just rest their hands on there. They also make gloves that can assist with gripping those bars. But this is a great option for someone who doesn't necessarily have the arm strength to hold onto a walker and hold themselves up, but can kind of use some of their forearms to help support that weight. Another option in the top corner is that's another type of rollator. As you can see, it's very similar to the platform walker. It's a platform or what we call a raised rollator, so a little bit taller option for someone who maybe has more upper extremity involvement. This is a great option, especially for someone who has strong goals for maintaining their posture and keeping their chest upright. I like this option for someone we're focusing a lot on respiratory training, like getting that deep breath in and not flexing over. But again, it's on four wheels. From a balance perspective, we need to make sure you're safe with it. So something you'd want to assess with a physical therapist to make sure it's a safe option for you. All right, I wanted to cover orthotics because I do consider this an assisted device for walking and standing. Going through orthotic considerations is outside of the scope of this talk. It's very complex and there's so many considerations, but I just wanted to point it out to you if you're not familiar with it. if you are working with a physical therapist or any kind of rehab team member, your doctor, anyone can prescribe an orthotic to you, and then you would get partnered with an orthotist. We have them at Shirley Ryan. There are independent clinics that are just for orthotics that you've probably seen. And then most hospital systems are affiliated with some sort of orthotist clinic as well. These two that I have on the screen. These are examples of what we call ankle foot orthoses. Your rehab provider might throw out the term AFO. So these are braces that fit on your foot and then eventually fit into your shoe. When a lot of people, when we say orthotics, they think of just the in shoe insert that maybe you have used if you've ever had plantar fasciitis or foot pain. But this is a little bit more stable. And also offers a lot of what we call active assist, meaning your leg muscles are having trouble maybe lifting your foot or stabilizing your knee as you walk. Maybe you're feeling like I take a step and I feel like my knee is buckling a little bit. Things like this are great options for external support to better support your leg based on any kind of weakness or coordination issues, things like that. Some of the things we have to think about when we are recommending orthotics is what's your current lower extremity strength? All right. What are you able to do, especially in the realm of lifting your toes and your foot while you're trying to walk, bending your knee when you're trying to walk so that you can clear the ground as you take a step? All right. And then things like what are activities that are important to you? Are you someone who at this point you're like, I'm mainly in my house and I'm not looking to do too much, or walking is still high priority task for me? I want to be active, I want to be outside, things like that. And then also range of motion considerations. Especially in your ankle and your knee. This is just a plug back to exercise that as someone with ALS, as you progress or maybe weakness progress, range of motion is so, so important because it drives how we position you in a wheelchair or position you in orthotics. And it can really make a huge difference in the way we're able to facilitate maybe continued standing or walking and things of that nature. So just a plug for continued stretching and really, really focus on, especially in the ankle and the knee, stretching into those harder positions. And then again, orthotic clinics and referrals, they're pretty prevalent, pretty much any hospital system. It would be something that you mention to your doctor, say, I'm interested in learning more, or meeting with an orthotist to see if this is something that could help my walking and standing, and they can certainly write a prescription for it. And the last piece of equipment, just as far as standing goes and walking goes, I did want to present what we call a static stander. This is just one option of them. There are many different options of this. This is one of the most common ones. In my clinic, we use these a lot. It is a great option for someone with ALS who has found that walking and standing, even with a walker, is becoming more and more difficult. But we still want to engage in activity that in standing. There are so many benefits to standing. I listed some here. We talked about maintaining range of motion, managing spasticity. Spasticity is that cramping that a lot of people feel, or what we call tone, which feels like my muscles are zinging and just like turning on when I don't need them to be turned on. A lot of people just describe it as this constant tightness feeling. Any sort of weight through your bones helps to build that bone mineral density. So preserving bone mineral density over time, especially in women. Standing, you're in a position where gravity is working against you, which can help a lot of that bowel and bladder function just to get things moving. All right. And then it also, as I mentioned, offers that supportive position for ADLs. I have people that have standers at home. They stand to, when they eat, they stand to do their morning hygiene routine. They stand to watch TV sometimes. They might stand to write or do something. As you can see, these standards most usually have a desk in front of them like that. So I have people that will stand and maybe do an upper extremity strengthening routine or something of that nature. This is something that a lot of insurances cover. Some do not. But again, something that you and your ALS provider could talk through. What are the benefits of this? And maybe what's that process like? Again, similar to orthotics, it would be a prescription for this. And then most insurances require that you trial this device with a rehab professional several times before submitting for authorization for it. All right. And then we've covered some of these, but just wanted to kind of give a summary slide on some of these things that we consider. Like I mentioned, we really want to assess balance ability and think through the course of your balance decline. We know with ALS that we're not going to stop that progression, but can we help plan for it in the equipment that I recommend? So if you're standing and walking now, can we think a few steps ahead in what you might need? Considering standing, sitting position, do you need any sort of external head or trunk control? All right, really thinking through fall prevention. What sort of caregiver assistance is needed, not just for you, but to manage equipment? Something like I just showed you, that static stander requires a second person to help pump you up. Is that available to you? And if not, are there other options? All right. And then things like household considerations. This, for example, like a stander, it's a rather large piece of equipment. All right. Do you have space for it? Um, and it looks like I listed household considerations twice. I apologize for that. But going back to, we talked a little bit about financial and insurance coverage. Um, that is a decision that I allow my patients complete autonomy in. I want to be here to say, hey, these are your options. And this is what insurance will cover. This is what they won't cover. You and I, let's brainstorm what's important to you and figure out if there are other options. All right. Thinking through delivery timeline. Delivery timeline meaning once we trial a device and we determine, I think this is a great supportive device for standing or walking or whatever it is, what's the timeline for my insurance to approve it and for it to get to me? All right. Things like a power chair or custom wheelchairs, that's a longer process, can sometimes be six plus month process. So do we need something in the short term, or can we wait a little bit more? I will say just on that, that's often one of the pieces of feedback I get in my clinic is a lot of people say, wow, like I got so much information about equipment from my doctor when I first met with them, and it was a bit overwhelming. And I say, I 100% agree. I feel you. And so let's try to talk through each of these and break down so doesn't feel so overwhelming. But the only time we really push into that is because we're trying to plan for the future. With ALS, going back to that first slide, is it can be unexpected. All right. So can we plan for the next month, but also can we plan for the next 3 months, 6 months, year out? Oftentimes I try to find ways for it to be less overwhelming for patients, but that's when we bring things up early. And then I mentioned just maintaining activity level. I will say this is one of the biggest barriers for patients is I want to continue to walk and stand. I don't want to use a wheelchair right now, but I'm having a lot of trouble getting through my workday, or I'm having a lot of trouble getting through a holiday with family, or keeping up with family on vacation, something like that. So it's always a conversation of us talking through what are the benefits to using wheeled mobility, meaning, can I use a wheelchair, a transport chair, or a power chair? Can I be more efficient and maximize my social participation or my participation in work activities from a seated position? I always want to encourage patients that using a wheelchair is not a failure. All right. It just offers an avenue for you to say, hey, I don't have to pour so much effort into walking and standing. when I'm seated, I'm able to do a lot of the things that I wanted to do when I was standing, but didn't have the energy to do. All right. So another conversation to have with your rehab provider. All right. Oh, this is what I was just talking about. Should we continue walking or using a wheelchair? Um, and going back, like I just said, I always strive to let my patients lead this conversation. What matters to you, and then what keeps you safe. My job as a rehab clinician is to say, these are my recommendations. Here's how I understand it, that it might be helpful. Here are maybe some of the harder lines that we have to cover to keep you safe, and identify some of the barriers to your safety. But other than that, I want to help you make a decision that works for you and your family and your lifestyle. All right. So when we talk about power wheelchair and manual wheelchairs, this is a whole nother topic we could talk for hours about our different types of wheelchairs and options. I just wanted to kind of prep you not to make a decision on a wheelchair, but to show you what are some of the options and then to talk through what are some of the questions I should be asking when my rehab provider brings up maybe the possibility of a wheelchair. So this kind of goes from most independent with walking down to least independent. So on the red chair, that's just a typical transport chair. You can buy these. These are not custom chairs. You can buy these pretty much anywhere. This would be for someone who maybe is walking but longer distances, going to appointments, going to the store, longer social activities is hard. Offers a great option just for a wheelchair follow if needed. These are generally lightweight, very transportable, can fit in a standard like trunk in a car. So a great option to start with. And then we get into more manual chairs. This is also a transport chair in the middle, but a little bit heavier duty. We can have manual chairs that are what we call custom manual chairs that allow the user to wheel themselves. This one, you can wheel yourself in this, or someone can push you. Often, that manual chair for someone with ALS is often skipped over. That does not mean that it's skipped over for everyone. All right. Again, we want to figure out where you're at in your journey. Um, but often propelling yourself in a wheelchair can be very labor intensive, especially if you're starting to see any upper extremity or hand weakness. So often we will move from walking to maybe walking and needing a transport chair at times to then just go straight into power mobility. Again, I just really want to emphasize this that using a power chair, using any sort of wheelchair, not a failure. All right. We are wanting to maximize the priorities that are important to you. All right. The power chair is a great option. There are people who are way more skilled than I am, and that we have many hospitals have wheelchair clinics. That's all they do, or they just specialize in recommending wheelchairs, down to head support, joystick options. So if you don't have the hand function to use a joystick, there are different options for controlling the wheelchair independently, to leg rest, trunk support, where the wheels are placed. Does it tilt and recline? What are your needs for supporting maybe respiratory equipment on there, and different things that you might need. Also, if down the line you were to need a communication device, like an assistive augmentative communication devices, we can fit one of those devices to a wheelchair. Super common. So definitely a conversation that we want to continue with a rehab provider and a wheelchair and seating clinic and your ALS doctor. Excuse me. So when we think about preparing for that wheelchair evaluation, um, if you're considering a wheelchair or your physical therapist's doctor has kind of mentioned, like it might be time to look into a wheelchair, that can be an overwhelming process because there's a lot of options. One thing I think is very confusing is, what does my insurance cover? Or if my insurance doesn't cover, can I self pay for some of these things that are important to you? Again, I want to respect people's autonomy and let them decide what's important to them and figure out are there options to help you get some of these things. First thing is talking to your doctor, getting a referral for a wheelchair. That generally will state things like wheelchair evaluation, maybe for power mobility or a manual chair. All right, but things that you and your family can do before this evaluation are just list out what are your mobility goals. Are you someone who, you know what, I'm really struggling with walking and standing, so I want to really use a wheelchair primarily to start doing things that I want to do? All right. Or, you know what, I'm not having that many issues right now. Maybe I just need it for going in the community for appointments, but I want to plan for the next 3 to 6, 12 months. All right. So thinking through your goals and what's important to you, what's currently difficult, and then how maybe has my ALS progressed, and between me and my PT or me and my rehab provider, what are some things that I want to consider as far as safety, trunk support, pain, head control, things like that. Making a list of some household considerations, especially with power mobility. Are my doors big enough to fit a power chair? All right. So, one thing I always tell people when they go into a wheelchair evaluation before you go, measure your doorways. All right. That's a great information for your wheelchair and seating team to have. If you don't have it at that first eval, that's okay. They're probably going to ask you to go home and measure your doorways and get that information back to you. And then also transportation considerations. With power mobility, not something that can just fit into a normal standard car. Do you have options for transporting a power mobility, or are there options in your area to transport power mobility? Rideshare services often have adaptive seating vehicles now that can manage a power chair. And then going back to insurance coverage, be your biggest advocate, right? Call your insurance and say, hey, I'd like to get information on what is covered for a power chair for me or for a wheelchair in general. This gets very technical. All right. You do not need to be an expert on that, but advocate for yourself and go ahead and get that printout and say what's covered, and so that I could maybe bring it to my evaluation with me, and you and the wheelchair and seating team can talk through what those options are. All right. And then when we just think about equipment, this is going back to, I know there's so many needs. I think Les Turner is a great place to start. I was just on their website. I gave this to a couple of my clients this week, actually. They have listings for things like grants and equipment loaning programs. So, a great place to start if for some reason there's a piece of equipment that insurance won't cover, or maybe you're early on in the disease process and you're like, oh, I really want to try to get a walker, but I want to make sure insurance will cover my wheelchair. It's a great place to start to talk through with care managers on what's available to me. I also just a plug Shirley Ryan. If I just tried it this morning, if you just Google Shirley Ryan Ability Lab Lending Closet, if you're in the Chicago area or the Illinois area, really, it offers about 30 different lending closets all over the Chicagoland area. I know that this is not a nationwide search, but for those of you outside of the Illinois area, you can probably Google in your area, whatever city and equipment lending closets, and there are probably resources for that area as well. So a great place to start. All right. And then we talked a lot about what do we consider? What are maybe some of the challenges? I wanted to speak to what does it look like when I say partner with your ALS provider? One thing that I really love to see, and we have done such a better job of in the Chicagoland area, is just early involvement. Even if you have a diagnosis and you're like, nothing's really changed, I'm just feeling some tightness, or I'm feeling a few functional changes, but nothing has changed. Go ahead and ask for that rehab evaluation. I recommend go ahead and getting a baseline evaluation for physical therapy, occupational therapy, and speech language pathology. This just allows us to set a baseline for where are we starting and to start the conversation about where are we at and where are we headed. It allows me as a rehab provider to educate, to offer up a lot of education on maybe potential equipment, potential caregiver needs, potential considerations in your home. It also, if you are not already connected with a multidisciplinary ALS clinic, it allows someone like me to start that process with you and to get you involved with a multidisciplinary clinic. That is a plug for the ALS Association. That's a nationwide search tool for multidisciplinary ALS clinics. Great place to start to make sure you're involved with a clinic that specializes in the management of ALS. All right. And then just a few considerations when partnering with a rehab professional. A lot of people say, well, what is this going to look like? And does this mean that I get to work out with a PT every week? All right, ongoing. All right. That's not what it means, but I want to point out what it does mean. All right. So, seeking out a physical therapist or an occupational therapist, typically, PT will think more through balance, walking, strengthening, trunk control, things like that. OT will generally think through activities of daily living, like eating, dressing, bathing, caregiver training, bathroom assistance, and things like that. All right. But there is also a lot of overlap. Right, like I mentioned, getting those initial evaluations to assess current and future needs, and then starting to partner with a physical therapist and occupational therapist who can talk through appropriate exercise programming. That includes setting you up with a home program for stretching, strengthening, aerobic conditioning, and then also starting to train your respiratory system. There are lots and lots and lots of resources out there that speak to just the safety of people with ALS participating in moderate intensity exercise and how that can change the progression of the disease over time. So, just another plug for you guys to get involved with a physical therapist and to start learning more about how exercise can affect someone with ALS. And then, as far as scheduling goes, I often will recommend to someone to get those initial evaluations to talk through current safety needs and training needs, go over any sort of patient and care giver or care team education. Is there an immediate need to train someone on how to safely transfer you, how to assist with ADLs and hygiene needs and things like that? Is there any immediate equipment training? All right. Or are there things that we need to plan for? Plan for again in the next couple months to year. And then, so I generally will see people for an initial evaluation and somewhere in the realm of 2 to 4 weeks to cover all of that initial kind of education and onboarding. And then I'll set up more of a skilled maintenance therapy. So maybe I check in with you once a month, once every other month, or as needed. I always tell people, hey, shoot me an email, give me a call if you're noticing any big functional change that we need to get you in sooner. But starting you on a really strong home program that you and your care team both feel confident in, and then having you check in with me to continue to upgrade or modify that as needed. I put these two logos on the right side. If you are interested and you have not already partnered with a rehab professional, these are two great places to start. The Academy of Neurologic Physical Therapy and Choose PT is just the General American Physical Therapy Association. They both have nationwide search tools that you can search for someone. If you search for someone that just says with just ALS experience, you may come up short. It's not that specific, but you could search for someone who has what we call an NCS. You'll see those letters behind my name on this presentation. Just stands for our board certification in neurologic therapy. Should be very proficient in managing ALS and talking you through the needs. So it would be a great place to start. If you're in an area that does not have widely available PT services or rehab services that center around neuro needs, there are a lot of telehealth options available. At Shirley Ryan, we offer telehealth. There are many clinics throughout the country that offer telehealth, so always an option as well. All right. So just some of the summary things that we went over that just remembering that progression of ALS is unique to each individual. We focus on unique needs versus living by an algorithm. All right. Early partnering with an ALS provider to assess current safety and mobility needs and planning for future changes. Thinking through the use of assistive devices and adaptive equipment to not as a failure point, but to maximize function and minimize fatigue. And then always advocate for yourself by considering what are your mobility goals, what's important to you, and then what resources do you already have available, and then what might you need in the future, so that us as your rehab providers can help plan for that. And that is it. I would love to open it up to questions. I'll stop sharing my screen here.
Anna, thank you so much. We do have a couple questions. I'll first start off with a comment. Somebody just wanted to mention, and I think it's definitely worth sharing to the group, that their wife has a power wheelchair that turns into a manual wheelchair, and he can fold it up, put it in the back of a truck or a regular van or an SUV, and that it's been helpful for them over the last couple years. They said the brand is Bangerin. I don't know if I'm pronouncing that correctly, but really great option for people that are maybe looking for um, a little more flexibility. Um,
I will just one plug before we go beyond that. I
yeah,
love that suggestion. Thank you so
yeah.
much for whomever wrote that in. I always want to be careful about
Mhm.
recommending things like that just from a financial perspective.
Yep.
Generally, insurances do not cover any of those specialty wheelchairs like that. Fantastic option. I have a couple clients who use wheelchairs like that. But just again, going back to a conversation with your insurance and what's doable for you and your family.
Mhm. Yeah. That is always a really, really important piece. Um, okay, someone has a question on head and neck support. Any recommendations for that? I know that can be really, really challenging as the progression of ALS kind of continues. Any advice on that?
Sure. This is something that
Yeah.
I wish it was less clumsy. I feel
Yeah,
that this is an
I
area
know.
that's clumsy. But oftentimes, I'll just say first and foremost, if you are already partnered with a rehab team, most orthotics clinics have neck braces and neck support that you can try. All right. If you are already using a power chair or a manual chair, there are many different head and neck support options. If you are not currently needing like assist all the time, but just having a hard time holding your head up, you feel like your head gets heavy throughout the day. There's a lot of neck break options. Sorry, neck brace options. I am blanking on the name right now. I found a photo of it on my phone right now, but I can't think of the name right now. The optimal. It's called optimal neck brace. It is you can find it actually on the ALS Association too. It is it's a neck brace that offers some foam support around it, but it's open
Yep.
so that it doesn't feel. A lot of people feel so claustrophobic in a neck brace. So it's two foam bars versus that soft neck brace that you've probably seen in movies and things like that. So that could be a good starting point for someone that's just having maybe some trouble holding their head up throughout the day.
Mhm. And that could also be a really great collaborative project. I know you had mentioned um, at your clinic, you can collaborate with other like rehab engineers, and um, so that could always be something too, because it's also very okay to come to your physical therapy appointments and say, like, this isn't working, or it worked for a little bit, but now it's just not working the way that I want it to. What can we do? Like, that's an okay thing to say, right, Hannah?
100%. Yeah. A lot of this is trial and error. And that's why I think it's great to get plugged into a place, if possible, that has some of this expertise because they're most often going to have equipment that you can at least trial before you go and invest a lot of money in it. But if it doesn't work for you, then don't buy it. I don't want you to waste your money. And if it doesn't work, let's come back and modify it. Like Anne mentioned, we, at least at Shirley Ryan, have an option to partner with a rehab engineer that can make some small modifications to equipment. And we want to get equipment that's going to work for you. Yeah.
Yeah. Okay. A couple questions about hands.
Mhm.
Um, so somebody has a question about aids for hand mobility. So I may have you maybe talk a little bit about that. And then
Yeah,
there's another question. So any advice on anything that can help with hand mobility?
sure. That's a great question. I will say this is one of my most frustrating areas
Yeah.
in the world of ALS. Um, as if you're talking about hand mobility as far as, let's see, bringing your hand to your mouth to eat or something like that, there are assistive devices. We refer to them often as an exoskeleton. You
Yeah.
might picture Batman or something, or a Marvel superhero with that, but they're becoming much more prevalent. There are devices out there, two in particular that come to mind. One is Armeo,
Hmm.
that you could Google and look at. One is Jayco makes another device, they're active assist devices. So they do not do the movement for you, but they really focus on bringing active assist and letting you lift your arm with some assistance. I will just again be transparent. These are 99.9% of the time never covered by
Yeah.
insurance and are very expensive. Very, very expensive. We actually, I was having this conversation with someone yesterday, and we are trying to figure out, her and her husband are trying to figure out, can we build something like this?
Right.
Because there's just not a lot of options out there. If you're just talking about the actual hand and positioning, there are tons of splinting options, tons of adaptive utensils, and things like that. It would be a great conversation to meet with an occupational therapist about, who can evaluate and really assess what would be most beneficial.
Yeah. And then kind of building off of that hand question, um, what are what are some questions that somebody might want to bring into an appointment when they're trying to decide between like a rollator or like a standing rollator?
Sure. If you're considering a rollator versus a standing rollator, thinking through your balance, like we mentioned before, thinking through, I think the biggest difference on that is hand and arm strength. With just a regular rollator, which is sort of like holding onto a walker down by your waist, if you do not currently have the grip strength to hold on to that, then that would not be a safe option for you. A rollator also has brakes, manual brakes on the front, that most of them you brake by pulling it, sort of similar to a car. So if you don't have the hand strength to pull the brakes, not a great option. Um, an upright rollator, again, if hand strength is an issue and you don't have strength to hold those brakes, not a great option. There is one brand of an upright rollator called a U-step walker.
Hmm.
It actually works by, you brake by letting go of it. It's a very soft grip to, it's sort of like gripping is like stepping on the gas pedal and releasing is stepping on the brake. So I do have several people with ALS that have that as an option because it's a little bit easier to coordinate with hand weakness. But I would think through, from a posture perspective, am I having any difficulty like holding my chest up, holding my head up? Do I need more support upright? So think through my posture, think through my hand strength, think through my arm strength. Do I have the arm strength to really grip and hold onto a walker while I'm walking longer term?
Is it okay to ask, like, can I see these models? Would most clinics maybe have a couple options to even just like see or try out?
Yeah, most Well, I don't want to say most.
Yeah.
It really
I
depends on
put
where
you on
you're
the
at.
spot.
I can speak like in the Chicagoland area, yes.
Hmm.
I'm sure more smaller communities, rural areas may not. It
Hmm.
could be an option where this is, hey, I know that, driving an hour and a half to go to PT every week isn't feasible, but is there somewhere close by that I can make a one-time visit and say my goal of this visit is to try out equipment and go and maybe try out some of this stuff?
Yeah.
Yes.
And this kind of leads in nicely to what you had mentioned about loaner closet. So, as Hannah mentioned, we have a loaner closet for folks that attend the clinic at Northwestern. But ALS United, that would definitely be something that you're going to want to look into in your area. Or the ALS Association would have loaner closets in your area if you're associated with like a multidisciplinary clinic. Um, it might be a great option to call them up, see do they have that equipment? Could you use it during your physical therapy session? Or could I use it for a little bit and then further decide, like, you know what, not for me, let's go with option B. Or, hey, this worked out really great. I'm going to continue to use it, and I'll return it when I don't need it anymore. Okay. Uh, Options for turning in bed, pulling up, and cleaning. And I think this, when I think about something like this, Hannah, um, I know that not everybody can receive like home health, but if you're going out to a physical therapy appointment, that's definitely worthy of saying, hey, can we